All right, perfect. So again, thanks so much for inviting me. It's always a pleasure to make new friends, and hopefully, some point we'll have the opportunity to do this in person rather than on this COVID time when everything is virtual or whatever. So for the last many years, we've been working on trying to understand what happens after there is an insult to the brain. And that can be whether it be an ischemic insult or an inflammatory insult, or in the case that I'm going to be talking about, mechanical insults. How that sets off a cascade of cellular molecular events. Some of those cellular molecular events are probably maladaptive in that they can promote further secondary injury and result in a less favorable outcome, but some of them are also probably adaptive, or certainly some are adaptive, that can help to limit the effects of the injury and can help in promoting repair and regeneration. If we can tease out this complex cellular and biochemical events, and hopefully we can tweak them one way or the other in particular patients, we may be better off in terms of improving outcome. So what I'm going to start off with is a historical note. I'm going to bring this up to a slideshow. I'm going to start off in a historical note, in fact, a prehistorical note. Traumatic brain injury is not something that gets talked about a great deal in neurosciences, but in reality it should, because it's among the oldest, probably one of the very oldest maladies that affect humanity. In fact, even before we were humans, there is evidence of a South African Australopithecine skeleton, right? This is a pre-human ancestor from 3 million years ago. And this particular individual was murdered by another Australopithecine who hit him over the head with an antelope humerus. It's pretty clear that one of the first things we did soon after coming down from the trees and discovering that we had opposable thumbs was to use that opposable thumb to grab a club and hit another humanoid on the head with it. This is just the nature of our species. And in fact, the Edwin Smith surgical papyrus, which is from the 26th century before the Common Era, is in many ways a textbook of trauma surgery, and very well described in there. Patient number 9 in the Edwin Smith papyrus is an individual who suffered a traumatic brain injury during combat, had contralateral motor deficits, etc. And this here is a skeleton, a mummy from a king in ancient Europe. And as you can see, this individual was also murdered as a consequence of a head wound. But this is more than just anecdote. There is data behind this. And many studies in cultural anthropology done in many places throughout the world. These particular studies were done in South America. But whenever anthropologists have looked at ancient burial sites and have studied skeletons at ancient burial sites, somewhere in the neighborhood of 10 to as many as 40% of all skeletons found in these ancient burial sites have evidence of skull fractures, either healed skull fractures like this one where someone recovered, or in some cases lethal skull fractures like the one I showed you in the prior slide. Our ancestors lived, and by the way, we know that skull fractures are only the tip of the iceberg, that many traumatic brain injuries do not result in skull fractures. So it is almost certain that TBI was an almost universal experience of our ancestors during evolutionary time. And any genetic variants that would either have promoted repair or recovery, or would have provided resilience and hardiness against traumatic brain injury, are probably genetic factors that would have been selected for by evolution. And many of these are going to have important roles in inflammatory disease and ischemic disease and everything else. So obviously we are more civilized now than we were in prehistoric times, and not all of us have been exposed to traumatic brain injuries, but it's still a very, very common disease. So in the United States, the latest CDC data indicates that approximately 2.5 million people show up at an emergency room every year with a traumatic brain injury. Obviously, the vast majority of those are mild injuries, but a fair number are moderate and severe injuries. About 10% of those people, about 250 to 300,000, end up getting admitted every year. meaning that their injury was of sufficient severity that they had to be admitted to the hospital for at least one night. And obviously many of those are fatal injuries, approximately 50,000 fatalities a year. Now, because traumatic brain injury is a disease primarily of young people, although as I'll show you in a moment, elderly people are increasingly at risk for it. But it's primarily a disease of young people who survive and live for many, many years with the disability resulting from their TBI. The estimates are that somewhere around 2% of the US population is living with disabilities resulting from TBI. And this is almost certainly an underestimate, because this is counting major motoric disabilities and more minor disabilities that can still be disabling, right? That would still result in problems with cognitive and other neuropsychiatric problems are probably not counted in these statistics. This is in fact the single most common cause of death and disability in young people. In young people, cancer, heart disease is relatively rare, but in this most important stage in life, TBI is the #1 cause of death and disability, and obviously at enormously high costs to society. So this is the outline I'm going to talk to you over the next 45 minutes or so. I'm going to talk about some recent trends in the epidemiology of TBI. I'm going to talk a little bit about how biomarkers will have an evolving and ultimately critical role in the management of TBI, and certainly for clinical research in traumatic brain injury. We're going to talk a little bit about sports-related concussions. This is not something that I have personally done a great deal of research on. My research is kind of skirted along the lines of sports-related concussions, but this has certainly received a lot of attention in the media and in the lay press recently, so it's worth talking a little bit about it. And then finally, I'm going to tell you about some of our more recent work over the last several years in developing a therapy for a particular endophenotype of traumatic brain injury, and how that is an example of the intellectual approach that we're going to have to bring forward if we're ever going to be successful in developing therapies for TBI. So what is an endophenotype? I've already mentioned this twice, including in the title. Well, it's a $25 word, and the concept that it tries to get at is really not necessarily that profound. An endophenotype is an internal or an intermediate phenotype that is closer to the underlying pathology of the disease than the visible phenotype, right? A visible phenotype, by definition, is usually a categorical variable, meaning the person has the disease or they do not. In contrast, an endophenotype, by definition, is a continuous quantitative variable, right? So it's something that you have to be able to measure it, and people have different degrees of this particular endophenotype. And as a consequence, an endophenotype has to be measurable because it's an internal thing. It's not observable from the outside. It has to be quantitatively measured through a physiologic, biochemical, or an imaging technique, right? So in a sense, it's something that is intimately tied in with a biomarker. Now, some of my colleagues don't like the word endophenotype, and they prefer to use endotype and subphenotype. I'm a lumper, not a splitter, so to me, these three terms are synonyms, but sometimes you will hear these other terms used in the literature referring to the exact same thing. So that all sounds pretty ethereal, so let me give you an example of endophenotypes in disease that we know a lot about, meaning coronary artery disease and atherosclerosis. So for a given patient that has had a heart attack or has had angina, meaning that they have coronary artery disease, there are potentially many endophenotypes that contribute to different degrees in different patients to the expression of that ultimate phenotype. And that includes things like hypertension, hyperlipidemia, vascular inflammation, and there are potentially many others. And obviously there are genetic inputs into hypertension, just like there are environmental inputs into hypertension, hyperlipidemia, vascular inflammation, what have you. Now, the reason that is important is that when we have therapies, and we are fortunate that in heart disease and coronary artery disease, we actually do have very effective therapies. The therapies are not directed at the phenotype, right? The phenotype is too complex, and the therapies have to be tailored not to the phenotype, but rather to the endophenotype. And whenever a cardiologist examines a patient with coronary artery disease, what they do is they measure the blood pressure, they measure the cholesterol level, they measure the CRP and potentially other biomarkers. And the therapy that is chosen for that patient is tailored to the endophenotypes that are active or predominant in that patient. For example, it makes no sense to give everybody with coronary artery disease a blood pressure medicine, right? It makes sense only to do that in people who are hypertensive. And if you do that in people who are hypotensive, you're going to make them worse. And unfortunately, that's the problem that we've had in a lot of areas of medicine, and certainly in much of neurology, right? That we have not bothered to appreciate the complexity and the endophenotypes of many of our diseases. And that probably accounts for a lot of the reasons why we're having trouble developing effective therapies for neurologic disease. So what are the endophenotypes of traumatic brain injury? Well, we don't necessarily know them all, but we know enough that we can say that inflammation, diffuse axonal injury, diffuse vascular injury, and potentially many others are contributing to that ultimate phenotype. I'm going to focus particularly in diffuse vascular injury in the latter part of my talk, because this is something that my lab has been particularly focused on over the last several years. It's not to say that it's the only important endophenotype. They're all important to some degree, but you got to focus your work in some way if you're ever going to make any progress. So let's switch now and talk a little bit about the epidemiology of traumatic brain injury. So we've known for a long time that, and this is data from the CDC, and this shows you in the solid line emergency room visits, in the dashed line hospitalizations, and in this dashed line and the dotted line down here, deaths. And as you can see, TBI is a disease primarily in children, young children who tend to fall, and there's actually a lot of child abuse included in here as well. There's this early lump in midlife, in adolescents and young adults, and this is primarily from car accidents. This is when these young people start driving and behaving recklessly. The argument can be made that teenagers and young adults are not neurobiologically mature enough to be able to drive a motor vehicle, and I think this is the kind of data that maybe can support that. And then there is this late life increase in emergency room visits as well as hospitalizations and deaths, and this is mainly from falls. And as the population is aging, this is the group of people where epidemiologically the fastest growing group where TBI is occurring. Again, this is another way of looking at this data. As you can see, early on in life as well as late in life, you're primarily dealing with falls, whereas in this little bump in adolescents and young adults, you're mainly dealing with motor vehicle accidents. And this is true relating whether you're looking at emergency room visits, hospitalizations, or deaths. Now, this has been changing over the last 10 years, right? And again, this is more recent CDC data comparing what has happened from 2006 to 2014. So one relatively good news is that the number of hospitalizations and deaths resulting from TBI is actually relatively flat, right? So there haven't been much of improvement, there haven't been much of deterioration. On the other hand, the number of emergency room visits has almost doubled. It's way up, right? It's from, somewhere about 1.8 million to now to like pretty close to 2.8 million. And the reason is because of there are two reasons for that. One of them is, as I mentioned earlier, the aging of our society, right? So we are getting much older. Our colleagues in cardiology and oncology have gotten pretty good at dealing with a lot of those diseases that tend to kill people, and as a consequence, the population is living to be much older, right? 60 is the new 50, 80 is the new 65, right? So folks are living older, and as a consequence of other usually neurologic disorders of advanced age, right? Parkinson's disease, peripheral neuropathy, or what have you, they're not quite as good at navigating stairs or navigating around their house, and they tend to fall, and some of these falls tend to result in emergency room visits. So unintentional falls is a big increase. As you can see, motor vehicle accidents has actually been decreasing, certainly as a cause of hospitalizations, and that's because our colleagues in automotive engineering and automotive safety engineering have also gotten much better. And our cars are much superior now to what they were even 10 years ago with better airbags and seat belts and other safety features. So and certainly big fall in deaths from motor vehicle accidents. And the other thing that's happened is that, well, people are a lot more likely to come to the emergency room after a fall or another relatively minor injury that in the past they would have stayed at home for. And that is because there's been a large increase in the recognition by the lay public that not all of these seemingly mild injuries are totally trivial. One point I want to make, and this is from a paper we wrote a couple of years ago, that this CDC data is likely an underestimate of what's actually happening in terms of the population exposure to TBI. First of all, the CD data is based only on the National Hospital Ambulatory Medical Survey. So number one, it does not include anybody who did not go to the emergency room with a TBI, right? So people who get bumped in the head and they say, gee, I'm going to be okay, I'm not really going to bother going to the emergency room. And this is certainly the case with the vast majority of sports-related concussions. Those folks don't ever even go to the emergency room. It's very, very hard to get good data into how many of those people there are. But they're not all totally home free either, right? And particularly when they incur repetitive concussions, they can be into trouble. The CDC data exclude the military and VA health system. And I think we know that military and military veterans are at very high risk of TBI, both from their military service as well as from their lifestyle choices. We have a volunteer army, God bless them. These are the people that are out there protecting us. But the military tends to attract young men who are risk takers and impulsive. And these are guys that they all played sports in high school. They like to ride motorcycles. They like to go to bars, and they sometimes drink to excess, right? So we know that this is a population that has a very high rate of TBI exposure. It only includes those people with discharge diagnosis of TBI, and we know that discharge diagnosis of emergency rooms is often inaccurate. So in this particular study, we looked at not the CDC data, but another database that looked at actually what was being done in emergency rooms. And the estimate is that instead of 2.8 million, we're probably talking about closer to 4.8 million people who actually have an emergency room visit for TBI. And that's about 3.6% of all emergency room visits. So this is a major public health burden and burden to emergency rooms. Let's switch a little bit to talk about biomarkers, right? And biomarkers have been hugely valuable in advances in clinical research and in clinical practice for really many areas of medicine. That includes cardiology, oncology, really most areas of medicine where there have been major advances in therapeutics. Those advances in therapeutics have come on the shoulders of advances in biomarkers. Now, the brain, unlike the heart and a tumor, is a far more complex organ, and mainly because neural cells are so complex. And we know that the proteins that are expressed in the soma of a neuron are going to be different from the proteins that are expressed in the axons. They're going to be also different from the proteins that are expressed in the synapses. The non-neural cells like the astrocytes and the microglia are going to express yet another set of proteins. And finally, there are the blood vessels themselves that are likewise express different levels of proteins. And all of these different cell types are injured whenever you have mechanical energy impacting the brain. So it is very likely, in my opinion, that if biomarkers are going to be useful in the management and the clinical research in TBI, it's going to be more than one biomarker, right? Troponin tells us a lot about the heart. The heart's a pretty simple organ compared to the brain. We're going to need multiple biomarkers in order to do that from the brain, and likely going to have biomarkers produced by all these different cell types. Several years ago, the FDA and NIH got together and they operationalized and they came up with some strict nosology for different biomarkers, which is worth knowing about, right? Biomarkers have many different uses in medicine. You can have diagnostic biomarkers that tell you whether or not you actually have a disease, and that's useful, but that's not the only need for biomarkers, right? Sometimes diagnosis is pretty simple, and the need for biomarkers is more in the order for prognosis. So prognostic biomarkers, which are not necessarily the same biomarkers that are going to be diagnostically useful, rather will measure something at baseline, and they can inform about the degree of risk for disease progression, right? So for example, cholesterol is not a diagnostic biomarker for heart disease, right? You can have a high cholesterol level and not have an MI, right? Troponin is a diagnostic biomarker. On the other hand, cholesterol is a terrific prognostic, predictive, and even pharmacodynamic biomarker, right? Because it tells you that a patient with an MI who has a high cholesterol level is in trouble, is likely to have future MIs. It can tell you that that's a patient that is likely to respond or likely to benefit from being put on a cholesterol-lowering medication like a statin. And finally, it's a pharmacodynamic biomarker because you can use it to measure how well that cholesterol-lowering medication is working, right? So different biomarkers have different contexts of use and different types, and it's important to think about that when you're thinking or developing biomarkers for clinical practice and clinical research. And the other place is the particular setting within the medical practice where you're going to need a biomarker, right? You can need biomarkers in the pre-hospital setting, and these are going to be, they can inform whether or not someone needs to be taken to the hospital. They can inform whether someone needs to be taken to the nearest hospital versus someone who needs to bypass the nearest hospital and maybe go to a tertiary center where they can get more definitive care. In the emergency department, there's likewise a different need for biomarkers. These here can inform you as to who can be safely sent home. It also can inform you as to what other testing, such as cranial CT scans, may need to be done. In the intensive care unit, there is yet another need for biomarkers. Here, you're mainly focusing, identifying patients who are at risk for secondary injury, monitoring the progression of people over the first several days after the injury, figuring out which of them may need particular therapies. And there's certainly need for biomarkers, and a huge need for biomarkers, in fact, which has been relatively little researched, is to identify patients in the rehabilitation or in the chronic phase. By the chronic phase, I mean months after the injury, people who are at risk of developing complications such as post-traumatic epilepsy or post-traumatic dementia, and identify mechanisms of post-traumatic comorbidities, right, such as headaches and other neuropsychiatric disorders. So where are we in terms of biomarkers? Well, there's been a lot of work over the last many years, and I think that has led to two biomarkers, two proteins that are released from neural cells, recently were FDA approved for use in the clinical management and the clinical evaluation of patients with traumatic brain injury. So one of them is glial fibrillary acidic protein, or GFAP. This is an intermediate filament protein. It's highly specific to astrocytes, and it is elevated in the cerebrospinal fluid as well as the blood after TBI, including mild TBI. The other protein that was recently approved by the FDA as a biomarker test was ubiquitin C-terminal hydrolase. Unlike GFAP, which is expressed in astrocytes, this protein is really specifically expressed in neurons, and particularly in neuronal cell bodies. It's involved in the ubiquitination of proteins for proteasomal degradation, and likewise, it is released into the spinal fluid as well as the blood after injury, including after mild TBI. So the study, the pivotal trial that led to the approval by FDA of GFAP and UCHL1 is the ALERT study, which was published, as you can see here, in 2018. This was a real tour de force study. Over 2,000 participants were screened. Almost 2,000 actually had the biomarker test. Approximately 2/3 had a positive biomarker test, 1/3 did not. And the conclusion of the study was mainly looking to see, in terms both by severity and both by whether the CT was positive or not, the biomarkers were significantly elevated. And we're looking here, this is GFAP on the left, this is UCHL1 on the right. As you can see, they were hugely elevated, whether you're talking about everybody or only the subset of mild TBI. And the good news is that they had a very good sensitivity, not so good specificity, but a very, very good sensitivity for identifying those patients who have an abnormal CT scan, meaning those patients that are likely to need hospital admission versus those folks that can be safely discharged from the emergency room. In fact, the combination of GFAP and UCHL1, had a sensitivity of over 97%. Obviously, the very small number of surgically remediable lesions. I mean, even with almost 2,000 participants in this study, only 8 of them needed a neurosurgical intervention. The test picked up all of them. And if, in fact, these tools were implemented in emergency departments, we would be able to reduce the number of cranial CTs by about 34%, which is quite substantial, right? This would translate into big savings as well as reduced exposure to X-rays and ionizing radiation that could potentially be harmful, particularly for the developing brain. But that's really so far as we have. Whether or not this is ultimately going to be accepted in practice guidelines, we don't really know. I think this is a slide that I borrowed from Frank Peacock, who's a good friend. He's the chief of emergency medicine at Ben Taub in Houston, and he personally seems to have skepticism whether emergency room physicians will change their practice only based on the available data. So I think there's still a lot of research to be done in these biomarkers, and particularly the usefulness for prognosis. I think rather than just diagnosis, prognosis is going to be a much more important role. So what is going to happen with this is the Banyan brain trauma indicator. This is the box that it comes in. So this is the blood test that was in fact approved by FDA for TBI evaluation. My sense, as well as Frank's and a lot of other people, is that its use in the emergency room actually will be limited, at least on the point of care assays developed. And there is in fact a lot of progress in developing these point of care assays. On the other hand, it may well be useful in pre-hospital settings, right, where the decision needs to be made of, is this someone who needs to be taken to the emergency room or not, right? The decision that gets made really not necessarily based on particularly good data at accident sites or the sidelines of sporting contests. It can be useful in triage, right? Those people that are seen in the emergency room that you need to admit them to the hospital. The question is, do you need to admit them to an intensive care unit? Can you admit them to a floor where the nursing coverage is less intense and less, by necessity, and then clearly for a prognosis. This is going to inform you who is likely to recover relatively uneventfully from their TBI versus who is likely to have a more complicated course. Let's switch now to this issue of sports-related concussions, because I've already hinted at it here a couple of places, and it's something that has received a lot of attention, particularly over the last 10 to 15 years. I mean, it used to be when I started my career, whenever I had to go give a talk to a school group or to a lay group on traumatic brain injury, I would always mainly talk about car accidents and falls and how they could be serious, but I always had to include a slide or two on sports-related concussion, and the message was, you shouldn't just blow it off. It can be serious, and particularly if your son or your loved one has had more than 2 or 3 sports-related concussions, then it's something you really have to watch out for. And that's the message I used to have to say, because no one paid any attention to sports-related concussions before about 10, 15 years ago or so. On the other hand, by now, the pendulum has swung so much in the other direction that now, whenever I have to go give a talk to a school group or a lay group, the message is, sports-related concussion, it's not quite as bad as you think, right? There has to be a happy medium there where they have to be understood. But the reason that concussions are so common in sports, well, this has to say something about the nature of the human brain and the way that the human brain is wired. Remember that during prehistory and even during early history, right, human beings lived in a state of constant warfare with one another, right? We were constantly at war with the other band of humans in the next valley over. We were constantly raiding them, trying to steal their crops and steal their women. And if your particular band of humans did not evolve within your young males a set of genes and a set of neural circuits that made them, for want of a better word, made them good warriors, right? Meaning that they were courageous, but that they were also impulsive, that they were also aggressive, and basically they could defend you. If your band of humans didn't evolve these particular brain circuits, you probably died out and you were conquered and replaced by our ancestors who did have those genes and those neural circuits. As we became more civilized, right, and it became really apparent that war was a terrible thing, well, we had to do what we can to minimize warfare. But those genes and those neural circuits still existed, particularly in our young men. And that is why contact sports were developed. And the best example of that is American football. So American football was invented, it was actually adopted from an earlier British game of rugby, but it was invented in the United States after the Civil War. And the reason is because the professors, the faculty that they had all fought in the war, and that when they went back to teach students in the late 1860s and the 1870s, their students had been too young to fight in the war, and the faculty became very concerned that these young men had missed out on the opportunity for moral formation that they themselves had taken advantage of by fighting in the Civil War. So it started in the 1870s in the Ivy League, and it started because, and these guys wrote it all down, right? We have excellent documentary evidence that this is what they were thinking. They wanted to come up with a game that was the moral equivalent of war, right? That would teach the future leaders of our country, would teach them these martial values short of war. And the game, by design, was a very violent game. And in fact, in the first few decades of American football, it was very common to have fatalities on Saturday afternoons from young men playing collegiate football. The game spread very rapidly from the Ivy League to the Midwest, especially to the defeated South. By 1905, however, the memory of the war had started to fade. And the 1905 season in particular was a very brutal season. There were 18 collegiate football players who died in the 1905 season alone. And it got so bad that many universities, including Columbia, Northwestern, Berkeley, Stanford, actually outlawed football because the faculty was no longer, these were not guys who had fought in the war, and they said, this is carnage. We can't have our young students kill themselves playing this dumb game. However, Theodore Roosevelt, who was president at the time, and whose son had been a football player at Harvard, surmised that, well, we have to make this game safer. We can't have all these people dying, but we also can't eliminate it because it's too important a game. So this is very much the same debate that we're having now, right? So President Roosevelt called to the White House the presidents of all the major football playing universities in the United States, and out of that meeting grew out what we now call the NCAA, right? So the history of the NCAA was specifically to make football a safer game, right? And from that, it grew to do what it is now, which basically covers a lot of intercollegiate sports. We now know, and by the way, this is something that has been suspected for many years and was mainly brushed under the carpet, is that athletes who have been exposed to multiple concussions, to multiple concussive or even subconcussive brain impact, they are at greater risk in late life of developing this condition called chronic traumatic encephalopathy. And these are slides that are borrowed from my good friend Ann McKee at Boston University. And she's looking at tau immunostaining in this individual who had played football professionally and developed dementia in late life. And as you can see, there are these tau deposits that tend to be in the superficial layers of the cortex, also in the depth of the sulci, and also in the hippocampus. Obviously, what we would like to know is, well, can we use biomarkers to try and prevent this, right? Can we use biomarkers to try to identify in collegiate athletes when they've had a severe enough concussion that it requires them to be taken out of the game, or potentially requires them to change their sport, right? Switch from football or ice hockey to something like tennis, which is probably still a perfectly good sport to teach those same values of teamwork and camaraderie that we get from sports. So a couple of years ago, the NCAA and the Department of Defense came together to fund the CARE Consortium. So the CARE Consortium has followed 1,700 collegiate athletes and service academy cadets over a 3-year period, right? These were all collegiate athletes, 264 of them. So it's a pretty high group of people, pretty high percentage of these 1,700 athletes who were initially enrolled went on to experience a clinical concussion during the 3-year follow-up period. And they obviously collected blood and collected a lot of information. And I think what we're showing here is that collecting blood immediately after the concussion, there's already a bump in these biomarkers of traumatic brain injury that we know from emergency room studies, including GFAP, including CHL1, not so much neurofilament light and tau, right? So even a single sports-related concussion can cause release into the blood of these proteins that are associated with impact of neural cells and potentially even death of neural cells. And that happens almost immediately. By 24 hours, it's way down. This is not the case in emergency room cohorts. In those, obviously, they had a more severe injury. The levels are elevated, and it's usually down to normal by the time they're asymptomatic, or certainly 7 days after they return to play. So it's a very brief jump, but it's certainly there. Now, looking at only people who had loss of consciousness or post-traumatic amnesia, right? So most of these sports-related concussions, the athlete reports that they feel dazed, they saw stars, maybe they're a little confused, but they don't necessarily were unconscious for a period of time, and they certainly don't necessarily have amnesia. That occurs where the injuries were more severe, the greater degree of impact. And in those cases, as you can see here, the elevation of biomarkers is more pronounced. It tends to last longer. But the most important is that this particular biomarker called neurofilament light, which you recall from the previous slide, in someone who's had a simple concussion, really not much happens to neurofilament light. In these concussions that tend to be more serious, there is an elevation of neurofilament light, but more ominously, even after they are asymptomatic and even after the athlete has returned to play, the neurofilament light level actually continues to increase. And it's unclear what this is telling us, but it's very concerning, because what it may be telling us is that there is ongoing axonal rewiring and axonal regeneration as a consequence of this initial injury, and that persists for a long time. And in fact, it may not be a good counsel or good advice to allow these athletes to return to play within a week or two of their TBI. We may actually need to wait for many weeks, and this is not going to make football fans happy, but nonetheless, this is kind of what the data is trying to show us. In the TRACK TBI study, which is a study that I've been involved with for really many years now, this is an emergency room and hospital-based study. We find similar data, and it meaning that in these more severe injuries, these biomarker levels are elevated for a good long time. And these biomarker levels are associated with MRI abnormalities, right? So the standard imaging measure that is used in emergency rooms is a cranial CT. However, we know from every other area of neurology, every other field of neurology, that magnetic resonance imaging is a superior imaging tool compared to cranial CT. And when we have done MRI in people who are CT negative, which, as you recall, is the vast majority of people who've had a TBI, they do in fact have elevated levels of these biomarkers, right? So if your MRI is positive, even with if your CT was negative, the subset of those CT negative people, which is about 25% that have a positive MRI, their biomarkers are going to be elevated, right? So this is another way of perhaps in identifying those people who've had a minor injury, that small subset of people with a minor injury who are nonetheless are at risk of having long-term problems. For the last 15 minutes of my talk, though, let me switch to more recent work that we've been doing in my lab, trying to develop therapies, because it's one thing for diagnosis and prognosis, and that can be helpful in counseling, and that can be helpful in giving people some idea as to the natural history and how they're likely to evolve. What we really want are therapies, right? What we really want is to be able to give a drug or some kind of therapy, even non-pharmacologic therapies, that this individual is then likely to make a more favorable recovery than they would have made if they had never had that therapy. And for that reason, for the last many years, my lab, for the last 10 years or so, my lab has been focused on studying traumatic microvascular injury as an endophenotype of TBI. And the reason we're doing that is, well, for multiple reasons. Number one, the brain, as I think all of you know, is the most highly vascular organ in the body. The brain is approximately 2% of the body weight, yet it receives 20% of the cardiac output, right? So a fifth of all of the blood flow that your heart pumps goes to the brain, although it's a fairly limited, fairly small in terms of mass. And that's because there's a lot of metabolic activity going on in the brain, and it's highly important. It is said that every neuron has its own personal capillary. I'm not sure how they came up to that conclusion, but it's a highly vascular organ. The other feature is that because of the anatomy of the cerebral vasculature, and this, what you see here, and this is very elegant vascular corrosion cast preparation and scanning electron microscopy, is that the capillary bed to the cerebral cortex, which are this tangle of capillaries right here, they come off these penetrating vessels, right? And these precapillary arterioles, they start from, they branch off generally at right angles from the Peel vessels, which is floating in cerebrospinal fluid. They then pierce the pia, and they enter the brain parenchyma, and then they obviously go down a few millimeters, and they provide blood supply to the cortex. Now, because of the anatomy, because of the structure of these vessels, they are uniquely sensitive to the shearing and stretching forces that occur when you have mechanical energy impacting the brain. Now, we've known for a long time, this is from a lethal case, right? This is one individual who died as a consequence of a very severe traumatic brain injury. And you can see that there's these very diffuse thromboses within the vessels, within the venules and the cortex, as well as in the deep structure. So diffuse vascular injury has been recognized for a long time. And another reason my lab has been interested in diffuse vascular injury is that, well, we know a lot about therapies, and we know a lot about drugs that work on the vasculature, and understanding how these drugs may be useful as repurposed compounds for the management of traumatic brain injury might be very important. This is another example. This is, again, one of these precapillary arterioles. So what I'm showing you in this slide is one of these vessels right here, right where I told you that the mechanical shearing forces tend to be concentrated. So this is from a normal individual. Well, he's not normal because he's dead, but from someone who died from not a TBI, whereas this is from an individual who died as a consequence of a traumatic brain injury. You can see that these precapillary arterioles are very damaged, right? The wall of the capillary is thickened. It has all these folds and pits, and it's just a blood vessel that is not likely to be functioning normally. And by the way, this happens in lethal TBI, but it also happens in mild TBI, right? So this is an example of an MRI of a young woman who fell asleep at the wheel. She was driving back from college, had stayed up late studying for exams, fell asleep, her car ran off the road, and but she had a new car, and she had airbags and seat belts, and she had at most a minor TBI. If she had loss of consciousness, it was very, very brief. She came into the hospital, had a CT scan. The CT was negative, but she enrolled in this study that our colleague Larry Latour was doing at the time, and that included an SWI sequence. This is an MRI sequence that is particularly sensitive to microhemorrhages. And as you can see, this young woman had these microhemorrhages here in the right temporal lobe, as well as here on the right parietal lobe. One of them was associated with restrictive diffusion. So this is a mild TBI that is only recognized by MR, and likewise would have had elevated biomarker levels, are associated with these microhemorrhages. Similarly, and again, this is from work of Dr. McKee, these lesions of chronic traumatic encephalopathy tend to be associated around the microvasculature, right? And this is again an example where you have some blood vessels here, another blood vessel here. The perivascular spaces tend to be a very prominent place for these tau deposits. The drug that we were interested in were phosphodiesterase 5 inhibitors. Phosphodiesterase 5 are very useful drugs in medicine, and the reason for that is that nitric oxide is the main vasodilator in the brain, and the nitric oxide signal is turned off by phosphodiesterase 5 or cyclic GMP selective phosphodiesterase, right? And these drugs have found their initial place in medicine was found in the treatment of erectile dysfunctions, right? So these are drugs such as Viagra and Cialis, and there's a whole family of them by now. But they're useful in many situations where you have endothelial dysfunction, whether it be due to longstanding diabetes, longstanding hypertension, or in the case that we are studying it, that it's due to TBI, right? What they do is they potentiate nitric oxide signaling. They allow a suboptimal nitric oxide signal to be amplified and to last for longer, and therefore they can promote vasodilation that way. There have been some preclinical studies, I'll go over this quickly, indicating that in animal models of stroke and subarachnoid hemorrhage, as well as cryo-injury, Viagra, sildenafil citrate, is useful. In our study, in this particular study that was published a couple of years ago, we wanted to look to see whether single-dose Viagra could improve an imaging biomarker of vascular reactivity, right? So I'll kind of go through very quickly. This study was mainly in people who had had a moderate to severe TBI. They were generally about 3 years after their TBI. And the way the study was done is using the MRI. And so the patient is put into the MRI and they're connected to this Douglas bag, which is filled with 5% carbon dioxide, right? So 5% carbon dioxide is a very well-known vasodilator. When the research subject inhales the nitric oxide, that is enough to raise their end tidal CO2 from about 40 millimeters of mercury to roughly about 50 millimeters of mercury. And that produces a very robust and easily measurable vasodilation. And in these particular experiments, we're measuring the vasodilation by a change in the Bold signal. This, by the way, is a technique that was perfected by my colleague in Dallas at the time, Dr. Han-Zhang Lu, who's now in the East Coast, closer to our work at Penn at Johns Hopkins. So this is an example of what we see, right? This panel is a healthy control, and we're looking at the structural MR. We're looking at cerebral blood flow using arterial spin labeling, and here we're looking at cerebrovascular reactivity with this hypercapnia Bold technique. And as you can see, the CBF and CVR maps in healthy controls are very boring, right? The cortex is pretty red, the subcortical white matter is pretty blue, and gray matter, it doesn't give you a lot of resolution. On the other hand, if we do that, these are two different patients with traumatic brain injury. This patient had a normal MRI. This patient did have a minor lesion in the MRI here. As you can see, we find some holes in the CBF map, but more markedly, we find more and larger holes in the CVR map, right? So for example, in this individual, this part of the cortex, which looks pretty normal structurally, has normal resting cerebral blood flow, but the vessels in that part of the brain are incapable of dilating appropriately to hypercapnia, right? And same thing for the vessels in this part of the brain, as well as here and here as well. And this is another case where we kind of see the same thing, right? So there is a decrease in cerebral blood flow. That's pretty minor. There's a much more pronounced decrease in cerebrovascular reactivity. I think we've shown the data here, and this is published data. This is showing histograms as that effect, you do get a statistically significant but relatively modest effect size if you're looking at cerebral blood flow, which much more stronger, larger effect size, and much stronger statistical significance if you're looking at cerebrovascular reactivity. And not unexpectedly, I guess it surprises the list at the beginning, there's actually a very weak relationship between cerebral blood flow and cerebrovascular reactivity, right? There is, this was not quite statistically significant, and it's a very weak relationship overall here. What we did then, after measuring the baseline CBF and CVR, is we took the patients out of the magnet, we gave them a single dose of Viagra, 50 milligrams, waited an hour and put him back into the magnet. And what we found, then again measured the cerebrovascular reactivity with the hypercapnia method. What we found, if you do that in healthy people, and these were primarily pretty young people, their median age was 40, really not much happens, right? Young people make plenty of nitric oxide. There is no need to further potentiate the NO signal. There is no increase in vasodilation with these PDE5 inhibitors. And again, this is pretty well known from the literature in, young people are not more likely to get erections when they take sildenafil. It's only the elderly folks who have diabetes or hypertension have some reason to have microvascular dysfunction. On the other hand, if you do that in the patients who've had traumatic brain injuries, what you see is that in almost every case, there is a potentiation of the cerebrovascular reactivity, and that's true even people whose resting CVR was within the normal range. And here there is, of course, a relationship between the baseline CVR and the delta CVR after sildenafil administration. And then when we did this, looking, voxel by voxel, we found an interesting finding. Again, in a healthy individual, which is this top row, basically there is no delta CVR, right? This is really just noise, right? The difference between the pre and post sildenafil CVR map is essentially nil. On the other hand, when we did this in different patients, we found that, well, not all, but many of these moth-eaten holes that we found in the resting CVR were filled in, and it tended to be not in the areas right around the structural lesions, but rather in the areas at the side of the structural lesions, right? For example, this patient had a lesion here, as expected, the CPF was down, the CVR was down. There's really not much of an increase right at the level of the lesion, but next to it, there is a potentiation in the CVR. Same thing right here, where there actually wasn't a visible lesion, but nonetheless, there was a hole in the CVR map, right? Same thing over here. No visible lesion, CBF was normal, CVR shows there's a hole there, and that hole was almost completely fixed by sildenafil, by a single dose, right? So we've done a lot of other analyses and trying to find what is it about parts of the brain, and so we believe that cerebrovascular reactivity is a helpful biomarker of microvascular dysfunction in patients who have had traumatic brain injuries, and may even be a helpful predictive and pharmacodynamic biomarker for using drugs like phosphodiesterase 5 inhibitors. By the way, sildenafil is not the only drug that is widely used in medicine that could be used to repair microvascular dysfunction, right? We could have non-steroidal anti-inflammatory drugs, which, as we know, prevent thrombus formation. We could have inhibitors of the vascular endothelial growth factor, inhibitors of MMP9, number of different drugs that could potentially find a use in medicine in the treatment of TBI. And obviously, we're looking at even more novel measures of vascular dysfunction. One of them that we've done some work on recently with our colleague at Penn, Dr. Rajini Verma, is looking at free water imaging. We think that this may be a marker of inflammation, and looking at blood-brain barrier dysfunction using dynamic contrast enhanced MRI. And this is with our colleague in radiology at Penn, Dr. Jeff Ware. So in conclusions, I hope I've convinced you that the current classification schema that we have for traumatic brain injury are really inadequate for the development of effective therapies. We're going to have to understand the endophenotypes of TBI. in order to really have any chance at all of being successful in developing therapies, we're going to need biomarkers, which can be either molecular biomarkers or imaging biomarkers or even physiologic biomarkers. And I hope that I've convinced you that microvascular dysfunction is an attractive and potentially treatable endophenotype of TBI that can be targeted by drugs such as sildenafil and also potentially many others. So this is a slide of my team here at Penn. In fact, I need a newer slide. We have some new team members that are not reflected here. Also many colleagues both at Penn, within the Department of Neurology and my team, as well as elsewhere at Penn, Dr. Han-Zhang Liu I mentioned, who used to be in Dallas and now at Hopkins, and likewise our support over the years from both the NIH as well as the Department of Defense. So I thank you very much for your attention, and we may have some time for questions. I hope there is anyway.
Thank you so much, Dr. Diaz-Arrastia. This has been a very informative, and in fact, we have several comments on the chat or questions in the chat, but I'm wondering if we have any live question, or I'll go with the first one and let the audience get ready for their questions or comments. So from Dr. Xu, she comments that her understanding is that endophenotypes of disease may offer a more genetic homogeneous group as compared with the broad or without having that phenotype, to provide more great power to identify mutations, particularly multifactorial diseases. Has been like a genetic predisposition to worse or course or severity of type of TBI?
Well, so the term endophenotype was first used in the field of psychiatric genetics, right, which is a complex genetics field, and that was kind of the idea, right, to when you're dealing with a very complex disease, and early on there were a lot of problems with GWAS studies being successful in psychiatric disease. So the thought there was that if we could identify the endophenotypes, it would be easier in a sense to come up with genetic association studies that could be real and reproducible. And that's certainly a place for the concept, but I think that's a limited place, right? Because these complex diseases are a result of an interplay between genetics and environmental factors that interact in often very complex ways. The other answer is that yes, I am absolutely certain that there are genetic factors affecting traumatic brain injury, right? Which is a little counterintuitive, right? You're walking down the street and you get run over by a car. That probably doesn't have a whole lot to do with your genetics, except maybe to the extent that genetics have a role in impulsivity and inattention, which they clearly do, right? But genetics also have a big role in tissue response to injury, right? And I think we've known that for many years. I think experimental neurologists have known that if you do a certain injury on a C57 rat and you do the exactly same injury on a C57 mouse and you do the exact same injury on, say, an FBB mouse, you get a different injury. You get a much more severe injury on the FBB than you do on the C57. And for years, this was kind of brushed under the carpet, right? Because people were kind of embarrassed by that, and they didn't want to admit to the fact that their models were so dependent on genetics, right? If the argument would be, Jay, if there's this much difference in a C57 mouse and an FEN mouse, what, if anything, does this tell us about a human? And the reason is, well, it maybe tells us not that much about a human, but it tells you about the role that some particular genes are having. And the same thing is true between different strains of outbred rats and everything else. So I think there is no question that genetics have a role probably in every single human disease, including infectious diseases, right? Whether or not you get infected with COVID and whether you have a mild illness or severe illness almost certainly has something to do not just with the dose of the virus that you get, but also with your host genetics, as well as other environmental comorbidities, such as whether or not you have diabetes or what have you.
Certainly. So another question was This, you show us some biomarkers that were approved by FDA. Are they CSF or blood-based?
Those are blood-based, right? Yeah,
Oh,
yeah. There have been no CSF biomarkers approved by FDA. Those were approved based on a blood test, which obviously is a lot more practical for clinical use. And you know, there are many other biomarkers that are currently under very active investigation. I hinted when I mentioned the NCAA CARE study about neurofilament light, which I think has raised a lot of interest in the field. That may be a useful biomarker of axonal injury and may be telling us something about particularly the delayed axonal Wallerian degeneration that occurs at TBI.
there is a question from Dr. Andrea Mendez, and she's wondering if there are other white matter neuroimaging biomarkers other than DTI to study axonal injury degeneration. If not, how sensitive are DTI-derived metrics when compared to blood or CSF biomarkers?
Yeah, no, I mean, excellent questions, right? So DTI has been used for really quite a while now, almost 15 years to study axonal injury. And it's been a bit of a disappointment, at least to me. I certainly would have anticipated that by now, and we were involved in some of the very early studies with DTI, I would have anticipated that by now DTI would actually have found its way into clinical practice, and it hasn't for a whole sort of reasons, mainly because it's not easy to standardize the acquisition of DTI signals from center to center, from magnet to magnet. These are real important challenges. There's still a lot of advances with DTI. Our colleague, Dr. Verma, who I mentioned some of her work here at Penn, has been refining the use of DTI, and particularly she's been using free water imaging and free water correction of the DTI signal, and that appears to help. So there's a lot of work that remains to be done in DTI. My personal feeling, at least both from the point of view of clinical research and ultimately clinical practice, is that blood biomarkers, although they are not quite as far along, are ultimately going to be what really makes the difference. Mainly because getting an MRI on a TBI patient is a challenge. Getting an MRI every 6 hours is basically impossible, right? And we do know that the evolution of these lesions are pretty dynamic, certainly in the early period. So we're going to need blood biomarkers that are less expensive, easier to do, and that we can do sequentially, much like our colleagues in cardiology do with things like troponin in the management of people that have MIs. On the other hand, we are going to have to correlate that with imaging, right? Because in order for us to have a good sense of what the blood test is telling us, having imaging at some point along the course is really going to be important, and likely DTI is going to be the answer there.
Thank you. We have your questions, comments from Dr. Kelsey Baker. Could you mention what are the mechanisms behind microvascular changes in TBI? Are these changes that you mentioned in acute or chronic, or on both?
Well, they start acutely. So again, they're complex, right? So the neurovascular unit encompasses not only the endothelial cell, but also the pericyte. It has the astrocytic end feeds. There are microglial cells that are associated with it, and it's likely that all of these cell types are injured to one degree or another. I think the other thing that happens is that there is disruption of the blood-brain barrier, right? So with these stretching and shearing forces, you not only get dysfunction of the endothelial cell, and I think I've shown you that these damaged endothelial cells, certainly in the chronic stage, but we also have data in the more acute stage, are inefficient in making enough nitric oxide. But in addition to that, there is leakage of the blood-brain barrier, and I showed you at least one slide of the newer work that we're doing using DC MRI. That occurs acutely, but it persists, right? And it persists probably forever, right? So there is some repair of the neurovascular unit and of the brain vasculature after a brain injury, and in some cases that may repair the tissue to its normal functioning, but not in every case, right? And there are many cases where the neurovascular dysfunction is permanent, right? And one of the things we're very interested in is trying to see not only how that neurovascular dysfunction is is the cause of the acute and chronic symptoms that people have, right, such as the headaches, the memory problems, the mood lability, everything else, but also how those neurovascular dysfunction will lead to further neurodegeneration years and decades later, right? Because one, obviously, as I think I mentioned briefly, the work of Dr. McKee, we do have evidence that individuals who have sustained even a single moderate to severe TBI in earlier midlife appear to be at greater risk of developing dementia in late life. And our hypothesis is that at least some of that dementia is due to microvascular dysfunction.
And what about severity, progression?
I'm sorry, I didn't quite get
What
that.
about progression of the
Progression.
microvascular?
So I mean, that's an excellent question, right? So we know that with aging, the neurovascular unit and the cerebrovascular reactivity and cerebral blood flow get worse over time, right? These things peak in the 20s and 30s, and they are in a steady, like everything else, and everything is going south with aging, right? So what happens in TBI is, well, it gets worse and then it repairs to some degree, but not totally back to normal. And then the question is it then on the same steady downhill decline that everybody else is in as they age? And it's possible, and even there, that would be significant, right? Because of the TBI-related hit that they got when they get the age-related decline, they may cross the threshold for dementia earlier. Or it's also possible that people who've had a TBI are at an accelerated rate of microvascular dysfunction. And that's a great question, and we just don't know the answer yet, right? We are very keen on doing those studies, but they will take time.
Have you
And that can be the rationale for identifying these people early and perhaps putting them on therapies such as sildenafil with the goal of perhaps slowing down or preventing some of the age-related decline that may occur years to decades later.
Have you related changes in microvascular structure to any type of clinical scale?
You know, I think our studies are pretty early along those grounds. I think there is a relationship, but the relationship is weak, and it tends to be more associated with somatic complaints, right? Things like headaches, dizziness, balance, rather than with purely cognitive complaints. But I think it's very early days there. And it's likely that the relationship is going to be weak, right? That you know, we know that vascular injury is only one of multiple endophenotypes, and it's not going to explain the whole situation. I think if it explains part of the situation, we'll be happy, particularly if we can come up with a drug that will be curative or preventative of that.
Can you give your thoughts of neurophysiological biomarkers such as TMS in individuals with TBI?
Sure. Yeah, no, I actually, I'm very hopeful that physiological biomarkers will also be of use. You know, EEG has been used for a long, long time. So far, it hasn't actually turned out to be that informative, but I think if we come up with newer, more clever ways to analyze EEG data, particularly looking at EEG connectivity, which could be a measure of axonal injury. My own group, we're very interested in using near-infrared spectroscopy as a measure of vascular integrity and vascular dysfunction. So that's a physiologic tool that we think is going to have a lot of promise for you know, to measure the vascular injury endophenotype.
I'm wondering if we have any other questions or comments from the audience. Are we yet at the point where you would say if somebody has a mild head injury, like a bump in the car or with a door or something like that, just go ahead and have put some ice and also take some Viagra just in case, or
You know, I mean, I think that's premature. Um, you know, I mean, let me say the good news is that although these mild injuries are very, very common, right? About 30% of the population will have had a mild TBI at some point in their life, right? And I wouldn't be surprised if some of the audience right here has had a mild TBI from a car accident or a fall or a sports-related injury. The vast, vast majority of those recover completely after a few days, and there's really nothing to worry about. However, not 100%, right? There are approximately 10 to 15% of people, even after a mild TBI, whose recovery is very prolonged, and in some cases don't recover. And clearly, recovery after more moderate to severe TBI is less favorable. Although some people still recover. I mean, even after a very severe TBI, people who are in a coma and in the hospital for several weeks, you know, 10 to 20% of people, even at that most severe end of the spectrum, do make a full recovery to the point that they're able to function normally in society, right? Not that their brain is really ever back to normal. So you know, we don't yet have any therapies that will either reduce the rate of disability or accelerate the rate of recovery. We're busily doing research in that area. I'm very excited about sildenafil, but I'm not sure entirely yet. On the other hand, one thing we do know is sildenafil is safe for TBI, right? One of the things we're very concerned about in our study, given that many of our patients have headaches, right? And headache is in fact the most common adverse effect from sildenafil, right? People who use sildenafil for erectile dysfunction, about 14% of them report headaches. By the way, they're mild headaches. They continue taking it for erectile dysfunction, but they do report the headache. So in our study, we were very worried that our patients, who many of them have headaches at baseline because they were TBI, would report worsened headaches after sildenafil, and that does not turn out to be the case.
Dr. Diaz, thank you very much for that presentation. I wanted to ask about, I'm Camille, I'm a psych resident. I wanted to ask if there were any similarities between TBI and other mental disorders or substance use, depression, anxiety, or alcohol. Is there like
Yeah, no, I think that's a good question, and I think at a neurobiological level, you know, there's likely to be some commonality in you know, these disorders which lead to common symptoms, right? So neurobehavioral problems are very, very common after TBI, such as depression, anxiety, irritability, mood lability, etc., right? And it's likely that some of the same neurobiologic substrates are active, whether or not it's a secondary symptom related to a brain injury or potentially other acquired brain insults, right, such as strokes or subarachnoid hemorrhage from people who develop them just as sporadic, right? One of the things that we're also have been looking at is looking at the mesolimbic dopaminergic circuitry after TBI, right? Because the mesolimbic input into the limbic system as well as the cortex, it arises from neurons that are in the brain stem and then have very long projections into really very wide projections around the cortex. And because of this structure of these axons, they're also very sensitive to the shearing and stretching forces that occur after TBI. So there's a lot of suggestions that patients with TBI who have these problems with irritability, anxiety, depression, etc., is a consequence of disruption of these mesolimbic pathways, and that in principle they may be treatable with, you know, things such as stimulants, etc. You know, you wouldn't think necessarily that a stimulant such as methylphenidate or Adderall would be a useful treatment for depression, although it may be if the depression is due to TBI, or it may be even in sporadic depression if it's due to disruption of the mesolimbic circuitry.
It's very interesting. Stimulants are somewhat used in older people for depression, sometimes as an adjunctive therapy as well for antidepressants. So,
Right.
Interesting.
Yeah, there's a lot of research remains to be done in this area for sure.
Interesting. Okay, thank you.
Any other comment or question?
I sent you one, Gladys.
Yes.
Okay, I can read my question. So would you change the treatment whether the injury is in the majority in the gray matter, making cortex, for example, or in the white matter regarding the increase of vasodilation therapy?
It's an excellent question, and the answer is that we don't know, but I am convinced that when we do know, it will be different therapy.
Okay.
I think treating everybody with the same therapy, it's never going to work, right? We're going to have to understand at a highly granular level the injury in one particular patient and choose the therapy tailored at that.